Welcome to AETCM, the emergency medicine channel. So, we are in the pathway of respiratory emergency. And then last presentation, yesterday we started the one new topic, that is a common respiratory condition. In that, three major conditions we discussed. First is an respiratory infection, mainly the pneumonia we discussed. And then we discussed the Atlek disease we discussed, and then lung cancer we discussed. So in this part, we'll discuss the three more conditions. So first is an pulmonary edema. So by word itself, we can understand edema in the sense that is a fluid buildup in the body. So edema means the fluid buildup in the body, that is the edema. So we know the peripheral edema, angle edema, those are some common terms. No, anasarca, it's a generalized edema. So here pulmonary edema means the fluid buildup in the pulmonary lung, that is called the pulmonary edema. That is just an kg like a definition. So we can see the fluid buildup in the lung tissue and air spaces. Air spaces in the sense alveoli occurs when fluid from the blood plasma that migrate into the lung parenchyma. So I think no need of explanation much more. This is a somewhat understandable, easiest way of definition. Otherwise, still more, if you want advanced definition, means you can remember like extravasation of fluid, extravasation of fluid in the sense plasma, extravasation of fluid from the pulmonary vasculature into the pulmonary parenchyma or alveoli, not our pulmonary parenchyma and alveoli. So it can approach the pulmonary parenchyma or alveoli also. So here we mention I can draw one image. So this is the alveoli, this is the pulmonary vessels, capillaries, just imagine. So here extravasation of fluid or plasma from the pulmonary vasculature. So from the pulmonary capillaries, the fluid is enter into the alveoli or pulmonary parenchyma. That is the definition for the pulmonary edema. And then what are the classification we have? So mainly we are dividing into two categories. First one is a cardiogenic, non-cardiogenic. Cardiogenic in the sense otherwise known as a high pressure. Because of the high pressure, so this is the vessel means because of the high pressure inside the vessel, that will shift out the fluid to the surrounding area or circulating, that will shift out the fluid into the alveoli. So other condition, it is a high permeability. Permeability in the sense the wall get either it will affect the wall, otherwise the because of the here in alveoli you can see that is a thin membrane. So if any breach in the thin membrane, so easily the fluid will approach the alveoli or lung parenchyma. That is high pressure and high permeability. High in cardiogenic, what are the things where comes under means dysfunction of right or left ventricle, chronic hypertension, dysrhythmias or arrhythmias, ventricular tachycardia, supraventricular tachycardia, myocarditis. Still you can add the myocardial infarction, myocardial ischemia. So those are the conditions that will increase the pressure inside the vasculature, pulmonary capillaries. Finally, it leads to the pulmonary edema. In high permeability, so the thin layer get breached means the fluid will reach out the alveoli or pulmonary parenchyma. Those are the category of non-cardiogenic. So causes like acute hypoxemia due to an inhaled toxin, submersion injuries, damages, submersion damages, any drugs or trauma, severe shock, cardiac arrest, altitude change, because the high altitude to low altitude, suddenly if the person is traveling means that will cause the shift out of the fluid from the capillaries to the alveoli. And then assessment wise, some patient they may present with an pulmonary edema after the lengthy of journey, mainly air travel, otherwise flight journey. After the flight journey, they may complain the generalized edema, angle edema along with an pulmonary edema also. So this is because of the not taking the prescribed diuretic while the time of traveling. So while the time of if the person comes out to the after the long journey, he is complaining any leg edema, otherwise he is complaining any angle edema along with an pulmonary edema means definitely we have to rule out the any cardiac history, past history, he is taking any diuretic medication or not, that and all we have to rule out. So in auscultation wise, we have to in early stages of pulmonary edema, you can hear the fine crackles in the base of the lung. It become audible at the end of inspiration. So think it is an inspiration and then this is the expiration. So you will hear the crackle sound at the end of inspiration. So here you will hear the at the end of inspiration, here you will hear the fine crackles. Mainly where you will get means base of the lung. So base of the lung means base of the lung, if you want to assess means, so you have to approach the posterior side of the thoracic cavity, the scapular region. If you place your steth over there means, then you are assessing the base of the lung. So in early stage, but in the case of severe stages, that will the crackles up to the subscapular level, or it may reach to the apex of the lung also. So what they are focusing means, so first in early stages, all pathological because of the gravity that will collect in the base of the lung. So once if the disease get progress or getting severe means, it may reach out the upper region also, means first in the lower lobe. Again if the severe disease is getting severe means, it will reach out the middle lobe in the right side, otherwise in upper lobe in the both side. So it will reach out the upper lobe and then it will cover the airways also. That's why crackles up to the subscapular level or apex of the lung. And then increased tactile perimeters. So we know that is a vibration test. And then coughing up pink foamy blood tinged sputum, that is a classical sign for the severe pulmonary edema. And then management wise, first position the patient. So again I'm telling, the management wise you have to start with an your scene size up, initial 10-second assessment, and then assess the mental status, assess and treat the life threatening causes, airway, breathing, circulation, disability, exposure. After that we have to reassessment, everything we have to do. So mean the same times, what is the main thing we are focusing in pulmonary edema means, we have to first upright sitting position, or you can write as a comfortable position for the person. So we have to provide the comfortable position, and then we have to support the oxygenation and ventilation. So yesterday presentation we told what is mean by oxygenation, what is mean by ventilation, both are different. And then add on we told respiration also, just to refer that presentation. So we can provide the supplemental oxygenation, and then we can provide the non-invasive ventilation. So in our ambulance crew, we have a non-invasive ventilation means, with the online medical director support, with the help of them, we can use the NIV. Otherwise, if you don't know means, the NIV is a main management we are following in the inside definitive care unit, we are following the NIV. So NIV we know that is a two various modes, CPAP and BiPAP. So just for the sake of knowledge, I am sharing with this one. So CPAP and BiPAP. CPAP in the sense that will provide a continuous pressure, positive airway pressure, continuous positive airway pressure. BiPAP in the sense bi-level positive airway pressure. So continuous means here it will provide a constant positive airway pressure. Bi-level means while the time of inspiration you will get one pressure, and then while the time of expiration, again inhalation, again exhalation. That is the two pressure variation will be there. So that is called NIV, non-invasive ventilation. So and then management, main core management in the pulmonary edema, there we have one mnemonic like a LMNOP. So L in the sense Lasix. So Lasix, otherwise we can call as a furosemide. So furosemide is a loop diuretic. So what it will do, the Lasix what it will do, it will excrete the sodium and water, no? So it will act as a diuretic. So it will excrete the sodium and water. So there we told cardiogenic is one of the cause for the pulmonary edema. So in the pulmonary edema, again if it is doing that excretion of sodium and water means, that will reduce the preload of the heart. So that will reduce the preload of the heart. Mean the same time from lung it will excrete the accumulated fluid. That is the purpose of Lasix. Second is a morphine. So morphine we know it is a opioid analgesic. It will provide a analgesic purpose also we are using. Same time it have a mild vasodilatory effect. Mild vasodilatory effect. Again it will reduce the cardiac workload by the decreasing the preload. That is the other thing. N in the sense that is the nitrates. Nitrates again we know we have a sublingual nitrates we have, and then we have a nitroglycerin. So those are the some drugs we have. So nitrates main action is it is a vasodilator. Mainly vasodilator, it is a arterial and then venous dilator. Both side it will dilate. So by the time of if it is dilating artery means that will reduce the afterload of the heart. Mean the same time if it is reduce the venous, if it is dilating the venous means that will reduce the preload of the heart. So again it will reduce the workload of the heart. And then so next is oxygen. Oxygen, it is fully based on the person level of distress. If the person have a little distress means then you can treat, you can manage with a nasal pharynx or nasal cannula. Still more means you can go with an Hudson mask. Still more means you can use with an NRBM, non non-rebreathing mask you can use. So still the person have means based on the advice you can go with an NIV. So those are the steps wise of management of the supplemental oxygen administration. P is a positioning that should come the first. Because of the mnemonic purpose we are kept as a last, but the positioning is the first and foremost step we have to do. Either you can give the upright position or the comfortable position of the person. So second condition is a acute respiratory distress syndrome. So acute respiratory distress syndrome, otherwise known as the ARDS or shock lung, or in the case of neonates we are calling as a hyaline membrane disease. Hyaline membrane disease. So it is means diffuse damage to the alveoli. It mainly focusing on the terminal part, diffuse damage to the alveoli. So second one is a what might be the causes. So causes wise, first one is a circulatory shock. So various type of shock we know. So we have some obstructive shock, we have some distributive shock. Those are the shock is one of the cause. Second is a aspiration of gastric content. So aspiration also yesterday last part we discussed aspiration in the sense inhalation of anything apart from the breathable gases, that is called the aspiration. Either it may be a foreign body, either it's maybe a oropharyngeal or nasopharyngeal secretion, whatever may be, but that is other than the breathable gas, that is the aspiration. Here aspiration of gastric content, or you can call as a chemical pneumonitis, or you can call it as Mendelssohn syndrome. So those are the various name for the aspiration of gastric content. Either you can call as a chemical pneumonitis or Mendelssohn syndrome. And then next is a pulmonary edema, also one of the cause. Hypoxic event, also one of the cause. And then again is a barotrauma. Barotrauma means baro in the sense increased pressure. So increased pressure because trauma in the sense that will cause the injury. So the lung injury or lung tissue damage happen because of the high pressure. So that is called barotrauma. The other term is there, that is the volume trauma. Volume trauma in the sense because of the high volume, because of the high tidal volume, it will cause the lung tissue damage, otherwise lung parenchymal damage, lung injury. That is called volume trauma. So here we are not focusing on the volume trauma, just for the other term I told. So barotrauma is one of the cause. Direct damage to the lungs, directly the damage. What are the damage? Damage means pulmonary contusion, any other direct trauma to the blunt injuries. Those are the things comes under the causes for the our condition, ARDS. So again the pathophysiology, this is the excellent explanation I read in the Nancy Carolyn. So here we can see the picture of two things. First, it is in the normal condition. This is the ARDS condition. So we'll see one by one. In normal condition, what will happen means, so this is the picture. Here you can see the seashore is there, and then it's surrounded by an water. So this is same image what we have in our lung. So here you will have a alveoli that's surrounded by an n number of capillaries. Okay, so the seashore they are mentioning as a alveoli, the surrounded water they are mentioning as a capillaries. Okay, here you will have one thin membrane of alveoli. Through this your diffusion of gas and then gas exchange will occur. Gas exchange in a normal healthy human being, this is the alveoli, this is the capillary. So the through the thin membrane the gas exchange will happen. So this is the normal healthy individual. But in the case of ARDS happening why? Because means, so we told the various causes like a barotrauma is one of the cause, and then we told the pulmonary edema is one of the cause, and then we told the some condition like a aspiration. So on the time what will happen means hypoxic event, direct trauma, pulmonary conducer. So those are the time either there will be a disruption in the thin membrane of the alveoli, or directly the fluid in aspiration condition and all, the directly that fluid accumulate in the alveoli. So on the time what will happen means, so there will be a disruption in the layer, so in between, so nothing, no layer is there, so the fluid easily approach to the alveoli portion. So here they are mentioning like, sir, the tide is approaching the seashore. So while the time of approach, the tide is approaching seashore means three major condition will occur. So the tide, the water is reaching the alveoli means water is reaching the alveoli. So three major things. First one is a accumulation of fluid. Accumulation of fluid will occur. So whatever fluid come from the capillaries, that will accumulate the alveolar area. Second one is it will wash out the alveolar content. So it will wash out the alveolar content. Third one is it will leaves the debris. Otherwise it will leaves the waste particles, waste materials. So it will leaves the waste materials, waste particles. So first is a accumulation of fluid. So if the thing, it is a normal alveoli. If the accumulation of fluid happen means what will happen, so the air can't approach that alveoli, so it will affect the entire alveolar function. So it will lead to the hypoxia, hypoxemia, everything. So that is the main thing in the accumulation of fluid. The normal function of the alveoli get disturbed. So again, second condition is a wash out of alveolar content. Normally in healthy individual we have a surfactant. So surfactant, it is a substance that will prevent the alveolar collapse. Again, yesterday presentation in Atlec disease we told, in the time of Atlec disease, there will be a complete collapse of the alveoli. So once the alveoli gets completely collapsed means, it is more difficult to reopen that collapsed alveoli. That's why the Almighty, the God given a surfactant inside the alveoli. By this, the complete collapse of the alveoli will be prevented. So here it will wash out the surfactant. So what will happen? The alveoli again easily will collapse. Third thing, it will leave the debris or waste product. So here what will happen? Waste product in the sense, any dead tissues, any dead tissues it will leave. Otherwise, it will leave any bacteria, virus. Those are the debris. Otherwise, waste materials. So everything that will contributing in the ARDS. So each condition will decrease the function of the normal alveoli. That is called the diffuse alveolar injury. So what are the assessment? So the same assessment only, we have to document the oxygen saturation, we have to ask auscultate the breath sound, and then we have to ask if any suddenly the person worsening or improving, that other thing, we have to mainly we have to assess. More specifically in ARDS, we have to in while doing a manual ventilation means bag volume mask, bag wall mask, or if you are doing any mechanical ventilator means two major things we have to repeatedly we have to assess. First is a ventilation pressure, second is a oxygen concentration. So if you forget, otherwise if you missed out those two things means, again it will worsen the condition. Why means we will tell one by one. So first, this is the ventilated strategies. So either you may go for the transport between the hospital to hospital. That time you can use otherwise if you are using the in-hospital ventilator setup means, this is the appropriate thing we have to maintain in the ARDS ventilation. So that is one specific protocol we have, like a net protocol. If you want, you can go through the net protocol. This is the simplest form of the net protocol. Okay. So first thing, so if you're putting the person in ventilator means, first setting wise, it's a lung protective low tidal volume strategy. So we know the indication for mechanical ventilation, various things we have. In this ARDS, mainly we are putting the person in ventilator for the purpose of healing purpose. So healing ventilation. For that reason, we are keeping the lung protective, or it may be the low tidal volume ventilation strategy. Mode wise, we are keeping as a volume control ventilation. Tidal volume you have to put as a initially once after an intubation and starting of ventilation you should start up with a 8 ml per kg predicted body weight, and then in the interval of less than 2 hours you have to reduce the tidal volume 1 ml per kg at the interval of less than or equal to 2 hours until the 6 ml per kg. So 6 ml per kg is the ideal volume for the ARDS condition. So, but initially we are starting with an 8 ml per kg, and then step by step we are reducing until the 6 ml per kg. So, 8 ml per kg, if you want to put some other condition, if you want to put a person in ventilator, mechanical ventilator means there it is a normal volume. 8 ml per kg is a adequate normal volume for the person, but mainly in ARDS we want to give the lung for the healing purpose. That's why we are maintaining the low tidal volume. That's why we are mentioning is a low tidal volume ventilator strategy. And then frequency in the sense respiratory rate, it should not be more than 35 breaths per minute. So you can see the number of 35. Why we want to go up to the 35? Why not in 88 or 2022 means? So you have to remember the minute ventilation formula. Minute ventilation in the sense respiratory rate in the tidal volume. So that is formula for the minute ventilation. Here what we are doing, we are reducing the tidal volume. We are maintaining the low tidal volume, 6 ml per kg in the sense that is the low tidal volume. Compared 8 ml per kg is a normal, but we are keeping the low tidal volume to manage, otherwise to equalize this minute ventilation we are increasing the respiratory rate. That is the concept behind the, we are keeping the high respiratory rate or high frequency in the ARDS condition. So oxygenation goals wise, we have to keep the PaO2, partial pressure of arterial oxygen, 55 to 80 mmHg. If you are measuring SpO2 means 88 to 95%. Peep wise positive end expiratory pressure wise, you have to use the minimum of 5 centimeter in H2O. Plateau pressure in your ventilator itself, you will get a plateau pressure. There you have to maintain the less than 30 mmHg. If you are finding more than 30 means, then you can reduce the tidal volume. Thereby, so the minimum value is a 6. So 6. So you should not go below the 6. So 6 is a minimum value. From that, if you are finding more than 30 mmHg of plateau pressure means, if it is if it is a 8 ml per kg means, then you can reduce the 7 ml per kg means you can see the alteration in the plateau pressure. So IE ratio means here we are maintaining the inverse ratio. pH goal is 7.30 to 7.45. So normal we know it is a 7.35 to 7.45. But voluntarily here we are allowing the somewhat acidosis, means somewhat we are allowing the hypercapnia. So this is called the hypercapnia. So we are allowing a mild hypercapnia. So it is not a complete hypercapnia, mild hypercapnia. It is called the controlled ventilation. Controlled ventilation. It is other term for the controlled ventilation. Controlled ventilation in the sense we are allowing mild hypercapnia. So that's why pH we are maintaining is 7.30 to 7.45. So this is the ventilation strategy for the ARDS. And the next is a toxic inhalation. So the effect of toxic gas, the injury of toxic gas depends upon the water solubility. So water solubility, we are categorizing into 3 categories. First category is a highly water soluble. The thing like ammonia means it will cause the acute upper airway irritation. So once if the ammonia like a substance, highly water soluble substance that reaches your nasal mucosa or oral mucosa, otherwise nasopharyngeal, oropharyngeal means these are the upper airway. So initial constant time itself it will cause the acute upper airway irritation. So second category, it is a moderate water soluble like a chlorine, and commonly we are using household things, no, that is the chlorine. The effect depends upon the concentration and the amount of exposure. So based two major things, how much concentration we are using, how much amount we are using. Based on that, it will show the symptom of starting from the coughing, wheezing, crackles to the pulmonary edema. Until the pulmonary edema, still more it will go through the chemical burns. So simple coughing to the chemical burns, until that it will cause the chlorine. And then final category is a minimally water soluble. So these are the substances are more important. Initially the person may present this normal, so they won't feel anything, initial mild irritation, but they will feel fine only, but it will cause the delayed onset of pulmonary edema. So because it is a minimally water soluble, so it will reach out the it will cross everywhere your mucosa and then your airways. Finally it will lodge into the your alveoli. There somewhat you will have some moisturization, so slowly it will dilute and then slowly it will soluble in the water. Finally it will cause the irritation of your alveolar membrane, thin membrane. It will disrupt your alveolar thin membrane, it will cause the pulmonary edema. So this is most important case. So management wise, again the exposed should be substance should be immediately removed and then from the contact with the toxic gas, that's the first step. And then we have to provide the 100% of supplemental oxygen. We have to assist ventilation if the breathing is impaired or evident by the reduced tidal volume. Assist ventilation means where we are doing the bag wall mask ventilation. If the upper airway is compromised, mean then aggressive airway management like endotracheal intubation or cricothyrotomy we can go for. So if it is a severely compromised airway, means that mildly partially means you can do the endotracheal intubation. Otherwise if it is not possible completely blocked means definitely you can go with the, in pre-hospital we can go with a needle cricothyrotomy, that is one option we have. And then patient who have been exposed to slightly water soluble, the third category we told, no, that may feel fine initially but have an acute dyspnea many hours later. So it won't show any that bad phase now at the time of exposure. It will show in a later stage only. So when such an exposure is suspected, patient should strongly consider transfer to the closest emergency department for observation and the future assessment. So that is more important. If the person is refusing also, clearly explain the person and then try to transfer to the nearby ED for the observation and the further management. So do your best. Shalom.